like to introduce our guest speaker today, which is Professor Geoff Currie. Professor Currie started his career in nuclear medicine back in 1986 at St Vincent's Hospital, and he's worked clinically at Royal Prince Alfred in Sydney and University of California, Davis. Was that right?
Los Angeles.
Los Angeles, sorry. And in 2002, Geoff was appointed at Charles Sturt University, teaching and with research interests across nuclear medicine, radiopharmacy, medical physics, nuclear science and safety, and artificial intelligence. Currently, Professor Currie has current research collaborations with Stanford University, University of California, Davis, Baylor College of Medicine, Greater Poland Cancer Center, and the National University Hospital in Singapore, as well as TeleMed. He has more than 230 peer-reviewed journal papers, more than 200 conference presentations, 100 invited speaker presentations, 3 books and 7 chapters in other books, 11 research excellence awards, and more than $750,000 in grant funding as well. He has provided government and private consulting in the nuclear fuel cycle, from mining through to production and safety and waste management, and he leads the development and delivery for the Bachelor of Medical Radiation Science and the Bachelor of Nuclear Science and Safety, a graduate certificate for nuclear safeguards and security as well. So a suite of also 4 nuclear micro-credentials offering at Charles Sturt University. So with that very, very thorough recount of all these accomplishments, I'd just like to hand this talk over to Professor Geoff Currie. Thank you very much.
Thanks for the introduction. Can you see my slides that I shared?
Yeah, excellent. Yeah, could see that really nicely.
Okay, thanks. You left a 0 off the grant money. It's $7.5 million. So it's makes it
really? I'm so sorry.
Maybe that was my typo. Yeah, so thanks for having me. I was talking earlier to both John and Ned that nuclear medicine is a really important part of the overall Australian nuclear landscape, as well as the international nuclear landscape, but it's a pretty narrow part of the field. So I've tried to put a presentation together that tries to connect key parts of that and focusing on the things that are sort of shifting the landscape, the innovations that we have currently that are going to change tomorrow's practice. There's a lot of slides. We probably won't get through all of the innovations, so we'll just go until either time runs out or you all get bored and drop off. So we'll see how far we get. So general overview, I'll look at the principles of nuclear medicine as a refresher for those that want a little bit of an insight into that. Look at the overall global and Australian market status and the challenges confronting, some general innovations, and then I want to look at 2 very specific innovations in theranostics and artificial intelligence. We may run out of time for the AI. I could talk about it forever. So if time doesn't permit, then I'll come back another time and we can talk about the role of AI. So as a general principle of nuclear medicine, you have a radionuclide that in most cases, 80% of the time, it's technetium-99m. And that radionuclide behaves in a certain way from its physical properties. And we pair that with a pharmaceutical that has biological or chemical properties that behave in a certain way in the body. And as a result of that, the pharmaceutical will perform its normal physiological function in the body. And because it's tagged to this technetium or this other radionuclide, then wherever it goes, then we can see where it goes because we can see the emissions that are coming from technetium. Now, that's an imaging perspective. We also do therapy where the same principle applies, where the pharmaceutical will go via its normal physiological process and it will take a therapeutic radionuclide to then kill the cells that when it gets there. And so it's actually kind of a really innovative way of looking at the physiological approaches. And we often tailor that with anatomy, which I'll talk about shortly. And you can see the images down the bottom that there is some anatomical information associated with a CT coronary angiogram, that you can see some narrowing of the coronary arteries. And so that's really crisp anatomy. And then you can see the physiological patterns that are provided by nuclear medicine that correspond to that show areas where there's decreased blood flow. Because you can have a physical change that doesn't necessarily mean there's a functional change. And the image on the right is just the classic bone scan, one with metastases, so that all the dots in a patient with prostate cancer, and then after they've had some of the nuclear medicine therapy, that those metastases are less physiologically active. So in a nutshell, the summary of how nuclear medicine works is that you have an endogenous, so a natural compound in the body that behaves in a certain way. So it goes through the body. In this case, the image is being depicted circulation in blood and then elimination from the body via the kidneys. And so we actually get an exogenous version of that. Sometimes it's the exact same chemical. Sometimes it's just an analog of that chemical. And we attach it to a radionuclide and put it into the system, and it will follow the same biological pathway. And as a result of that, we can produce some images of where that goes, or as I said before, produce therapy where in the tissues where the tracer ends up. And so how it differs from X-ray, and they're complementary. Often they're done together. When you look at textbooks, they're called anatomy and physiology textbooks because they go hand in hand. And X-ray is the anatomy and nuclear medicine is the physiology. And you can see in the image on the bottom of the page there that on the X-ray you can see this exquisite outline of the structure of the bones. You can see some of the problems that we have with anatomical imaging, where you have a superimposition of small bones in the feet, wrists, ribs, and CT can be used to remove that. But the role of nuclear medicine is to look at the physiological impact. And so what you can see is these orange and red sort of spots, these yellowy spots that where you've got increased radiotracer accumulation, indicating a physiological difference. And we can co-register that to specific parts of the anatomy, because the anatomy on the bone scan is not great. So to ask, is this one side of a joint or is it two sides of a joint? That changes the pathology. And so of course, registering it with the X-ray allows us to see that it's one side of the joint. And then we've got this heel spur that's a little bit active as well. So that's a bit of an overview of what nuclear medicine is for those that needed a refresher. The global market, it's about 2 billion nuclear medicine procedures are done annually across the world. That's a fair number. And about 75 to 80% of those are reactor dependent. Most of those are technetium-99m from the molybdenum produced in the reactor. But there's others that are therapeutic tracers, iodine-131, lutetium-177 in particular are produced in a reactor. Samarium-153, yttrium-90, strontium-89, all those therapy agents that are really important for treating disease are also reactor produced. One of the most important tracers at the moment is lutetium-177. It's emerged in probably the last 10 years, and Australia has kind of led the world in some of the developments with its use as a beta therapy agent. And of course, iodine-131 has been around since the 1940s. It's the original theranostic agent, and it's still in use in the same applications that were emerged in the 1940s for treating thyroid cancer and hypothyroidism. So while the topic of the presentation is talking about innovation and change and the changing landscape, there is parts of the landscape that are, pretty geological. They don't change much over time. And iodine-131 is a classic example of something that is pretty much done the same today as it was, 60, 70 years ago. So the growth projections are pretty interesting. Nuclear medicine is about a $9.3 billion global market in 2023, and it's expected to grow to about $42 billion by 2033, which is not that far away. 10% annual growth is projected out to 2035 by the IAEA, and 50% of radiation-based therapies, so we think about radiation therapy, for example, is a form of radiation-based therapy. They're predicting that by 2050, that 50% of all radiation-based therapies will be nuclear medicine. Now, that doesn't provide a prediction that radiation therapy is going to decrease in use or retract. It's really saying it'll continue to do what it does, but we'll see this growth in nuclear medicine-based radiation-based therapies. And so 80% of that is reactor dependent. So in Australia, there's about 700,000 procedures done on the Medicare benefits schedule. Need to keep in mind that in state government hospitals, most of those patients fall outside of the Medicare data. So 700,000 procedures annually in Australia on the Medicare scheme. Using that, about every Australian on average will have about 2 to 3 nuclear medicine procedures across their lifetime. And these are life-changing and life-saving procedures that often come into play when other procedures fail. People don't come to nuclear medicine as a first resort for therapy or for diagnosis. They come to nuclear medicine when everyone else fails and they can't provide the answers or the solutions. So, it means that the patients that come to nuclear medicine, those 700,000, they're at a particular stage of their health that really it's their last straw, and any impact that nuclear medicine has is positive. But we're moving with diagnosis and therapy to what we call precision nuclear medicine or precision medicine, and we do that with things like theranostics and artificial intelligence, and I'll mention new radionuclides along the way. So you probably heard a few years ago that we had some production issues at ANSTO. And so this is just a little bit of a summary, just to show the complexity of the nuclear medicine environment. Now, in theory, on paper, Australia is, self-sufficient when it comes to production of many of these radionuclides, but particularly molybdenum-99 and lutetium-177. But it's far more complex than that. And the reality is that we have one reactor, the Opal reactor, which is the most reliable reactor in the world. It's a fantastic facility, operates 300 days a year. It has good output, good quality, but because it's a single reactor, it's a single point of failure. So any failure or scheduled or unscheduled maintenance means that that production facility is out of action. So it means that we'd rely on imports. And the global market's really important because, when we actually rely on these imports from Safari, for example, so if Opal's down, then we need Safari to produce our molybdenum, which they'll ship in bulk, and we can ship that directly into the Building 23, which I'll talk about in a moment. But we service externally as well. So you can see on the right-hand side that we overproduce our molybdenum, and we actually ship more molybdenum to the US than we use in Australia, a lot more, like 6 times more. And that's actually part of the global citizenship that we have here in Australia. And they use our molybdenum to produce generators in the US. But what that means is it also secures supply in return. So the A&M facility, which is a new facility that dissolves the molybdenum targets out of the targets out of the reactor and extracts the molybdenum. If it had a failure, or we have a generator production failure in Building 23, then instead of relying on molybdenum coming in from South Africa, we would need generators being produced in the US. And so during the 2019 crisis, we were actually and 2018 crisis, we were actually shipping Australian molybdenum to the US. They were putting it in generators and then shipping it back. And so that's part of the quid pro quo that we have going on. Now, the A&M facility, part of the 2009 problem was there was only a single line. It was actually originally designed and built with a redundancy processing line in there. That hadn't been commissioned at the time of the 2019 failure. So we're in a bit of a bother for 6 months. But now that the 2 lines are functional, so it means that there's redundancy built into the A&M facility. Now, both Opal and A&M are new facilities. But the third arm of that is Building 23. And Building 23 is over 60 years old. It's a single point of failure. The sushi train, so the belt that takes the activity through the different hot cells, had a failure back then, and it put us out of action for 6 to 9 months. And so we're very lucky that at the moment that facility is being planned for an upgrade It will probably take 10 years, but we will get there, and then we'll have this amazing facility where all three parts of the process are on a single site. If you go overseas, all those other sites have those three processes at either different sites, sometimes different countries, different states. So they have to cross borders, and you have decay during that time. So just to appreciate the complexity of the process that we have here in Australia. Globally, as I said, Australia, it has about 10 to 30% capacity of world production. We operate about 10%. But you can see that the reactors around the world, indicated by the red lines, the ones that are still currently operational, they're all older reactors that have been refurbished to extend their life, but they're still all approaching end of life. And when you look at them collectively, 20%, 30%, 20% of world production, if those go offline, we're in a bit of a world of hurt, especially since the black lines are facilities that have already been gone offline, including NRU in Canada, which produce 40% of the global market. So it's kind of a scary kind of landscape at the moment, because if one of those facilities goes down for regular maintenance and there's a problem with one of the second facilities, then there's a global shortage. But there's optimism. You can see here that the production of reactors that are planned moving forward are actually quite extensive. If you actually look at the purple line up here in Canada, the CANDU reactors, which are the power reactors that operate on non-enriched uranium, can produce 100% of the global market of molybdenum, for example. So that's building. And we have the Australian reactor that can do up to 30% of global demand. But then we have all these other reactors that are looking to replace existing reactors in Belgium, in France, the Netherlands, which are the big markets. South Africa's got a plan for a replacement of Safari. And then we've got all these smaller reactors that are coming in into the global market in Brazil, Argentina, India, and Korea. So it's optimistic in the future. We just need to get to about 2035. We'll probably blow out to 2040, so we can have that secure future that we all need for our ongoing health. Of course, reactors are not the only production method. This is just a quick summary, because there's a lot of talk about other production methods, particularly in the US, because the US has always relied on Canada, the NRU facility, to produce their molybdenum. And when that shut down, is that they relied on Europe and Australia. And so they don't produce it locally in a reactor. So they've got a few other methods that are looked at. You can see that the North Star production using proton accelerator, the SHINE process using the deuterons. The problem, and the Triumph program in Canada, which is the cyclotron production that everyone got excited about, particularly the anti-nuclear folk, suggesting that we can shut down Opal because you can produce technetium-99m in a cyclotron. Of course, we know that because that's how it was discovered many years ago, is that technetium-99m was discovered in a cyclotron. The problem with it is, you can see the far right columns, is that the production yield is really low. Even though the waste footprint is low, the production yield, and in particular the quality, you end up with a lot of chemical contaminants. So they're not very effective ways of producing it. And as a result of that, the Triumph project was not a triumph at all. It was a failure. And as a result of that, Canada is moving to the CANDU nuclear power project. So some of the innovations that have shaped nuclear medicine in the last few years and moving forward, I'll talk briefly about hybrid imaging. So that's combining different technologies. So your SPECT and your CT, your PET and your CT, and your PET and your MRI, which is combining that anatomy and physiology. Semiconductor detectors or solid state detectors. Digital technologies that drive things like DICOM, PACS, and telemedicine. Iterative reconstruction methods. Some of the new peptide labeling, which I'll talk briefly about, and total body PET, which is the long axial field of view, I'll mention briefly. And then I'll speak more about theranostics, new radionuclides, and artificial intelligence if time permits. So the idea of hybrid imaging has really changed the landscape in nuclear medicine, because what it means is that instead of just having those physiological images that you kind of got to hold our images up to an X-ray and try to sort of correlate the two of them together, or try to use software that brings things together from disparate pieces of equipment. Hybrid imaging is one piece of equipment that actually has multiple modalities. So your nuclear medicine with your CT or MRI. And what that allows us to do is image the patient simultaneously in the same position. So there's no movement or positioning errors in terms of registration. And it means that you can have your physiological information, as you can see here, and you can appreciate that even as a PET scan, the nuclear medicine scan, it doesn't have high resolution, but it's physiologically very precise. And then you've got your high resolution CT, and then you can merge the two of them together so you can actually co-register and look at it, the anatomy, where something is, confirming the anatomy. But importantly, it allows you to do attenuation correction. And what that means is you can actually measure the attenuation across each line of response and make a correction for that. So it actually improves the quality of your images and reduces artifact. So you improve the accuracy and efficiency of your overall process. So that's a really significant advance over the last few years. We've also moved to some of the newer detector technologies using semiconductors, things like cadmium zinc telluride. The problem with semiconductors is that you don't want them to have to operate under helium supercooling to operate your efficiency. And many of the semiconductors at room temperature have a lot of noise, and that degrades the image quality. And so we create semiconductors that have some impurities in them that allow them to operate at room temperature without that noise. And cadmium zinc telluride is one of the more common semiconductors that we use. And what that allows us to do is have higher sensitivity, better resolution, better image quality. Because we've got higher sensitivity, which means we're counting more information quicker, then it means that the imaging time is shorter, so you can do more patients, or patients, there's less motion, or we can image the patient for the same amount of time, but you reduce the radiation dose, which would reduce the radiation dose of the patient, obviously, but also reduce the cost of the procedure. And so you can just see some images here of the cadmium zinc telluride versus analog PET. And this is a SPECT scan and then digital PET. So these two compare, the conventional SPECT and CZT. So you're comparing those two, significant improvement, and then you can comparing the analog PET to the digital PET. Some of the other digital technologies around PACS, RIS systems, the radiological information systems, DICOM improves compatibility, the Ethernets, internets, and other networks that we actually allow sharing of information. And what this does is it reduces the costs, it improves access for patients, including geographically and socioeconomic barriers. It creates person-centered care, it's better resource utilization, and importantly, it reduces the carbon footprint of the overall procedure. So, and with all of that, obviously the efficiency and the cost reductions are really important. So these are important improvements that have changed practice. Iterative reconstruction, it's been around for a long time, but one of the problems is that the data that we have in imaging, whether it's CT, MRI, PET, and SPECT, is actually pretty dense data. And so we didn't have the computational technology that would allow iterative reconstruction on that kind of density of data. When they introduced PET at Royal Prince Alfred Hospital in 1992, the computing power that they had for one PET scanner was actually equivalent to the rest of the hospital put together, and that included the computers that ran the CT and radiology systems and the 9 gamma cameras that were in the general nuclear medicine department. So there was a huge step up in terms of the computing technology. What we have now, the computer sitting in front of me, is probably 1,000 times better than the computer that I first did iterative reconstruction on, 15 years ago, or 20 years ago, and that was considered a supercomputer back in the day. And so to have 1 or 2 hour reconstruction times is just not feasible. Whereas now iterative reconstruction occurs in a matter of less than a minute. And as a result of that, what iterative reconstruction does, instead of using filtered back projection, is it reduces the artifact. And you can see the image up on the right-hand side, where you've got this artifact that you have this starring appearance and then the cold appearance laterally. That's just a reconstruction artifact from filtered back projection that is largely removed using an iterative approach. I probably don't have time, and you probably don't have the interest in actually going through the process of iterative reconstruction, but just to know that reconstruction method is a significant advancement. Peptide labeling is really important. Back in the 80s and even before that, we were mucking around with radio labeling monoclonal antibodies, which are very large proteins. Wasn't really working very well, so then we're using fragments of monoclonal antibodies because make them smaller and they move a bit faster. But now what we're doing is we've identified that on certain types of tissues, certain types of cells, they'll overexpress certain cell surface receptors. Now, a cell surface receptor is just a protein on the surface of the cell that allows communication from the outside world to the inside world. So something that's really simple might be that the receptor, when it's activated, sends a message for the cell to divide and grow. Or it might actually be the opposite. It might actually send a message to say, stop growing, die, apoptosis. So there's different receptors that do different things, and each of them has a very specific set of other peptides or other small proteins that will either antagonize or agonize that activity. And so what we've been able to do is identify cell surface receptors that are overexpressed in certain kinds of diseases. So in the example down the bottom left, the somatostatin receptor is overexpressed in neuroendocrine tumors. And so there's 5 different types. And what we've been able to do is actually specifically target somatostatin receptor 2 with what's called dotatate, and doesn't go to the other receptors. And as a result of that, we can actually use it for delivering both therapy and diagnosis of neuroendocrine tumors. And so what it does, it provides targeted imaging and therapy. It's more precise, it's modular. And what that means is that as represented in the diagrams, you actually have a small peptide that attaches to the receptor. And then we just, without changing it, we have a little linker, a chemical linker, that allows us to actually attach different radionuclides. And the radionuclide is just substituted in and out, which I'll talk about in a few moments. So what it does is it drives precision medicine, and it allows us to really enhance what's going on in the theranostics space, which I'll discuss soon. But peptide labeling is not just about oncology. Most of it's in oncology, but we're doing things with brain imaging. So there's peptide labeling associated with, for example, Alzheimer's disease, where we're actually labeling things like particular peptides that will target the breakdown of beta amyloid and the plaque formation that's associated with that in dementia. Tau imaging, which is good for imaging both dementia as well as other degenerative changes associated with head trauma, for example. So lots of stuff going on in the brain and other body systems. This diagram just shows an example in the heart where we can actually use interestingly, the same agent, so the dotatate, which targets somatostatin receptor 2, because somatostatin receptor is also overexpressed on plaques that are vulnerable. And what a vulnerable plaque is when you actually have disease in your arteries, coronary arteries or your carotid. If it's vulnerable, it means it's got characteristics that are more likely to rupture and cause a significant issue downstream, which usually results in death. And so if we can identify those plaques, those restrictions in the vessels that are more likely to rupture, then you can have more aggressive treatment for those patients. And the ones that are less likely to rupture, then you could treat very differently. And so you can see here where we've got some monocyte approaches, a Nexin V which targets apoptosis, and then of course the dotatate which targets the overexpression of somatostatin on the monocyte. So it's beyond oncology. We kind of use oncology as the prototype discussion. Untitled body PET is also very innovative. One of the issues that we've had, if you look at the bottom left of the screen, is that conventionally PET is a narrow axial field of view, might cover 15, 20, or maybe even up to 30 centimeters of the body at a time. And so what it means is you've got to image the body in segments. And that produces its own issues of time and inefficiency and decreased count rates. And Simon Currie, who's a distinguished professor at UC Davis, and someone I worked with at UCLA many years ago, developed this amazing technology called uExplorer, which is total body PET, which essentially means that you're imaging the entire body at the same time. And now, while you might, on the surface, it might just seem that it's just a matter of putting a whole bunch of conventional detectors together to make it 2 meters long, is that it had to require a complete change in the detector technology. The lines of response, the amount of information that comes and needs to be processed simultaneously is enormous. It was not something that was an easy solution. But the advantage of this system is that you end up with 40 times higher count rate, which means that you can lower the patient dose, shorten the imaging time. It means that it's so sensitive that you can do delayed imaging. So some of the PET tracers have short half-life. Gallium-68 has a 68-minute half-life. Fluorine-18 has a 110-minute half-life. And so it means that you've got to image the patient within an hour or 2 hours of injection. Otherwise, there's nothing to image. But with the high sensitivity of this system, you're able to image the patient at 6 hours or 8 hours or 12 hours, or with fluorine-18 at 24 hours. And that can actually create some multiple time point imaging that allows us to better inform theranostics. Improved resolution, efficiency, and overall, you can actually reduce your cost by having higher throughput and decreased pharmaceutical costs. Now, of course, when this was first developed, a friend of mine and I tried to buy one. We had, or he had some funding. Someone donated $20 million to his facility, and we were at $10 million short. It was a $30 million price tag, so in Australian dollars. So it was actually pretty hefty, but there's smaller versions. So Siemens do one that's about 130 centimeters, so it's more like a half body. It means it doesn't do the legs. There's one of those at Royal Prince Alfred Hospital, at Royal North Shore Hospital, and at Peter Mac down in Melbourne. Again, fantastic images, but not quite the total body. Now, of course, a gratuitous plug, just before we move on to the next section. Simon Currie, who invented that system, he also invented the prototype, or he developed the prototype and invented the detector technology that allows PET and MRI to occur simultaneously. So to allow the PET system to be able to be inside the magnetic field required a complete redesign and development of the detector technology. And so Simon Currie was responsible for that. He's coming out to Australia for the World Congress in Medical Physics and Biomedical Engineering. I realise now that that's just a week before the ANA conference that on the 10th of October. Just a bit of a plug for those that might want to go to Adelaide, or if you're in Sydney, a week later, so immediately after the ANA conference in Sydney, he'll be speaking on the Saturday. There is options for a Saturday-only registration at the Rains conference, so you could email me for details if you're interested in that. That's the end of the gratuitous plug section, and we'll move on to theranostics. So the idea of theranostics is it's a long-held principle. It's not new. it's a portmanteau that represents the term diagnostic and therapeutic, so it just means putting them together. Iodine 131 imaging and therapy back in the 1940s was an original theranostic, but we've created this new word for it to reflect maybe a higher order capability and the idea of actually better pairing our radionuclides together for diagnosis and therapy. And so the reason I went through some of those other developments is because it's all related. They all drive advances with each other. So you can see that in blue, we've got our image analysis, quantitation. AI fits into our capability in dealing with big data and image analysis. So those developments feed into our improvements in hybrid technology for our imaging, our targeted therapies and peptide labeling for radionuclide therapies, produces our molecular theranostics. And then, of course, we have our other aspects of that where I'm going to talk about radiation dosimetry that further enhance our decision-making, driving precision medicine and better outcomes for the patients. And that's the overall goal, obviously. And it's a powerful tool in oncology because it benefits a number of particular scenarios. It provides more targeted therapy for cancers where other therapies might be more macro. So surgery, a big radiation field, systemic chemotherapy. So it's less targeted. So that sort of hits a lot more collateral damage to non-target tissues, whereas what theranostics is allowing us to do is having that micro approach, the more targeted approach. It also provides therapy for cancers that are not typically managed well by other treatments. And there's lots of those. So the reason that we do our neuroendocrine tumors with somatostatin receptors is because they're not very responsive. They're very difficult to manage with other forms of therapy, and the prognosis is not great for the patient. So we're actually adding something to it. The prostate cancer stuff that I'll talk about shortly is because it's filling a gap in the market where patients are slipping through treatment options because their restaging doesn't make them suitable for existing options. But the third arm of that is to be able to provide gentler options. Some patients come in with, they're older, particularly in oncology, they're older, they have other comorbidities, they may be non-compliant with their dosing regimes. And so sometimes they don't tolerate aggressive treatments, whether it's surgery or radiation therapy or chemotherapy. So these targeted approaches are a lot gentler on vulnerable populations. So the purpose of theranostics is to, firstly, using the diagnostic part, confirm the presence and the distribution of the target disease. So you know what you're targeting and how you're going to target it. If you don't have radiotracer accumulation, well, then obviously the therapy is a waste of time because you're not going to get the therapy tracer to it. But what you can also do is based on the distribution that you see in your images, you can then predict the likely response to therapy to identify those people who are more likely to be good responders versus non-responders. And that changes your therapeutic approach. And also to be able to identify how the radionuclide will be broken down and eliminated. So what non-target tissues, what will end up with a radiation dose. And then as a result of all that, we can actually start to predict the radiation dose to both target and non-target tissues. And if need be, if the target dose or the predicted dose to, for example, kidneys, because it might be eliminated via the urinary system, if the target dose to kidneys is really high or the patient has, borderline, renal dysfunction, well, then we might adjust the dose to reduce the actual collateral damage to the kidneys. And there's three approaches that we use in theranostics. The one's called targeted radionuclide therapy. They're all a targeted approach, but we just refer to this as TRT. And what you're essentially doing is you're identifying, and I'll give you a few examples in a moment, you're identifying pathways into a cancer cell, and then we're changing our gamma for a beta or an alpha. And sometimes it's the same channel or same pathway, and sometimes it's a similar but different pathway. So that might not be a true theranostic in all sense of the word. Then we have our radioimmunotherapy, which uses monoclonal antibodies or fragments of monoclonal antibodies, where essentially the monoclonal antibody targets a specific cell surface antigen, and all we're doing is binding, we're putting a chelation region on there with the radionuclide, and all of that remains unchanged. All we do is substitute in and out, whether it's a gamma, a beta, or an alpha emitter. And so that's genuine theranostic. And then we have our peptide receptor radionuclide therapy, which is our PRRT, which is what most people are excited about at the moment. And it's the system very similar to radioimmunotherapy, where you have a cell surface receptor that is targeted by a specific peptide. And again, we attach our radionuclide that's modular in nature to that. So this is an example of TRT treating hypothyroidism, for example, where we have iodine 131 as the therapy agent, iodine 123 as the diagnostic agent. They're in a form of sodium iodide. They go in through a sodium iodide channel and as iodide, and then the sodium breaks off. The iodine goes through organification, so it's trapped inside the cell, and the sodium is then eliminated via the sodium-potassium pump. So that's actually a true theranostic. But we can actually do our imaging where with something like technetium sodium pentactate that goes in through the same channel, but then is more rapidly eliminated via the same sodium channel. So it means it doesn't undergo organification. So for the first maybe 20 minutes, then it sort of represents the distribution that you would expect on your therapeutic agent. But after that, it doesn't indicate what would occur with the iodine for therapy. So it's not an effective, true theranostic. This is for bone therapy, and there's lots of different options that we have here. In the end, the goal is always about the hydroxyapatite crystal in the bone. So you can see that we've got strontium chloride and radium chloride coming in through a calcium transporter that ends up in the hydroxyapatite crystal. We've got our technetium MDP or HDP, our rhenium HEDP, and samarium EDTMP that would come in via our sodium potassium transporter into the hydroxyapatite crystal. And we've got our fluorine 18 sodium fluoride, which also comes in via an anion exchanger with the hydroxyapatite. So the end goal is the same, but these are not all the same pathway, and they will have slightly different distribution. So perhaps not all true theranostics. If we paired technetium HDP with samarium EDTMP, then we'd call that a true theranostic. If we compared MDP with our strontium chloride, well, then they're going to be very, very similar, and you're probably not going to tell the difference, but they're not necessarily a true theranostic. Radioimmunotherapy is really interesting. There's not a lot of options that we have with this. The CD20 cell surface antigen is one that's overexpressed in certain types of lymphoma. So you end up with a positive B cell. And it does a couple of things. So if the little green thing is your CD20 cell surface antigen, then lots of little processes occur. You can have the monoclonal antibody, which is rituximab. So that's MAB means monoclonal antibody. And it can stimulate direct apoptosis, which is cell death. It can attract natural killer cells that release cytokines that cause cell death, break down the cell wall. It can actually attract and start the complement cascade that causes lysis of the cell membrane and cell death. It can attract macrophages to cause phagocytosis. You can use chemotherapy agents to kill the cell, or we can attach a radionuclide to it for diagnosis or therapy. And often we do multiple versions of this, so we can actually use diagnosis and therapy using a radionuclide, and it may also have a chemotherapy agent attached. But what most of the resurgence in radionuclide therapy is associated with is PRRT using the peptide receptor therapy. And I've already explained the process. The key with this is that the receptors are neurotransmitters, hormones, antigens, chemicals or substances that are pretty small, and the proteins that target them are actually really small peptides. So as a result of that, instead of being these large proteins like monoclonal antibodies that move slowly through the body, then they actually localize fairly quickly, which also reduces the potential collateral damage. And so this is just a diagrammatic representation of that. Cancer cell, overexpression of your receptor, the part of the peptide that attaches and activates the receptor, the overall total peptide, so a lot of it is inactive. We find a benign part of that and attach a little chemical linker that we attach to a chelation region, and inside that chelation region it actually binds to either a gamma or a beta or an alpha emitting radionuclide. So that's just a larger version of it, showing that within that receptor there's specific kinds of binding sites. So this is looking at the somatostatin 2 receptor, where there's 2 binding sites, and this changes the selectivity for a given receptor. And this just talks about modularity that I mentioned before, that you can see the slight different chemical structures that we have. The overall chelator is the same, but you can see here that we have gallium-68, lutetium-177, and actinium-225, and these are all in a DOTA chelator. And then this is a slightly different format for the gallium-68 that has a linear chelator, so you can see that it's open at one end using a slightly different version of the chelator. But this is modular. While it's the same chelator, you can see that there's slightly different chemical bonds. And that's the theranostic challenge, is that, you know, realistically, that those small differences in chemical binding, in theory, would change their biodistribution, but the reality is that they're unlikely to. There's 3 general classifications. Your traditional same radionuclide, perfect, iodine-131 for both diagnosis and therapy. There's not going to be a difference at all. You can actually have those pairs of similar, same element, but different nucleides, so iodine-123 and iodine-131. Now, within that, the coordination chemistry is going to be the same with the yttriums and the scandiums, but you can actually get a mass effect that I'll talk about in the next couple of slides. And then the other version is where the radionuclides are very different, so gallium, lutetium, actinium, and that produces a few of its own kind of challenges.
Sorry, Geoff, if I could just offer a 5-minute warning, thanks.
Yep, sure.
Leave a little bit of time for questions. Thank you.
So as I mentioned, is that the mass-dependent isotope effect can create an issue, and specifically the kinetic isotope effect can alter the association constants. But realistically, at this point in the development, we're not seeing those things have a major impact on biodistribution. So the key to part of that is radiation dosimetry, and this is just a diagram that shows using lutetium-177, even though it's a therapeutic beta emitter, that it actually has a couple of gamma emissions that you can use for imaging, that you can image over the course of the scan of the therapy, to actually show its distribution in different tissues, plot that over time, and work out what the actual dose to target versus non-target tissue was. We can do that preemptively by using, for example, gallium-68 and gallium-67 are exactly the same radionuclide. Exactly the same element, different radionuclide. Gallium-67 is a gamma emitter. Gallium-68 has its short half-life. So gallium-68 doesn't allow us to predict the biological behavior over a long period of time, over a week, whereas gallium-67 would. So we could pair those together to do better predictive dosimetry, which means before you inject the therapy dose, which obviously would be more precision medicine. I mentioned that somatostatin was the prototype theranostic. I'll just sort of show you a couple of examples of that. So this is using a glucose tracer, and this is with the somatostatin tracer. So you can see the specificity that's showing up tissues that aren't showing up with glucose metabolism. But what it's showing is the tissues that will respond to therapy. And after 2 cycles of the lutetium therapy, you can see the improvement in the disease, both the FDG avid and the lutate avid, some residual disease. Here you can see that the high proliferation index with the gallium, with the FDG, with the glucose, responding to therapy 2 years later, almost all clear. Not quite, but almost. Prostate cancer is where we're really sort of sitting on now, and I'll probably just finish with that. But you can see that there's lots of different ways that we can get traces into the prostate with different molecular and biological functions. But prostate cancer overexpressed prostate-specific membrane antigen, and so we can target that using PRRT, using different radionuclides for diagnosis and therapy. And you can see we've got monoclonal antibodies that will do it. We've got traces that are gallium-specific, lutetium, and actinium as well, actinium being the alpha emitter. And so the key to that is the receptor has this kind of funnel. It's got a zinc active site, so it means that if this site is activated with zinc, then it becomes an agonist, whereas if it's not, then it's an antagonist, so it doesn't do anything to the cell. And so our different traces, so PSMA 617 versus PSMA 11, which are the two most common, this for therapy and PSMA 11 for diagnosis, you can see it doesn't activate the zinc site. The red part is exactly the same for both traces. And then we have these accessory binding sites that the PSMA 617 has, which allows it to stay resident for a longer period of time for therapy, whereas the PSMA 11 doesn't, which means it has a shorter residence time, but it's only got a 68-minute half-life. So as a result of that, that doesn't need to stay there for, 5, 6, 7 days. And this is the image of the year from 2018. This is from Hoffman down at Peter Mac, which just shows pre and post therapy in a range of patients. The red zones are those areas with a SUV above 3, which indicates prostate cancer disease. And then the image beside it is the post-therapy, which you can see overall has significant improvement in disease response. I'll skip a couple of these just to show you very briefly the alpha therapies, because we have a range of alpha therapies that have sort of moved into the market. Actinium-225 being the main one. The problem with actinium is that it's not a single alpha. It actually has a complex decay scheme, and once it becomes a different element, then its biological behavior might be a little bit different as well. So there's potential toxicity. But you can see it's more of a sledgehammer. If our lutetium is that nice little tack hammer chipping away at disease, then the alpha emitter is more like a sledgehammer. So you can see widespread disease, 3 rounds of actinium, almost gone, and then the 4th round. And in this particular case, this is a patient who had widespread disease that even with 2 rounds of lutetium therapy, you got advancement of disease, the disease got worse. And then in response to 3 rounds of actinium for the alpha emitter, you can see a marked response to the therapy. So I think that there's a whole raft of emerging radionuclides we probably don't need to go through. Bismuth, lead, terbium, holmium, they have a range of applications, which is going to make the horizon quite interesting. And each of those comes with some radio pharmaceuticals or some ligands that provide some interesting options for theranostic pairs. So I might finish there and leave time for questions.
Thanks, Professor, for such a thorough review and bringing us up to speed. So we've got a couple of questions I'll just quickly run through. So the first question from David Cohen was like, what is a typical whole body dose from a diagnostic technetium-99m scan?
Yeah, it's not very high. When you think about, you inject the patient with 1 gigabec of technetium, which is, 1 billion disintegrations per second with a 6-hour half-life, it seems like a lot. But you're talking about, between most nuclear medicine scans for SPECT, between 1 and 5 millisieverts a whole body dose. and PET is a little bit higher. CT, then you're looking at 10, 15 millisieverts or high up to 20 millisieverts. So pretty low on the grand scheme of things.
Yeah, that's great. And second question is from Ned. He just asked, can nuclear medicine have an impact in understanding and treating psychiatric disorders that I think are and will be more and more a greater killer of society? Is there any application?
Yeah, there is, and they're not even. There's a new emerging radiopharmaceuticals for psychiatric disease, but it's a long-standing part of the landscape. And what it is that we use different radionuclides is that to image the brain under different conditions. So we can look at a variety of psychiatric disorders during an event, on medication, looking at response to medication. We can look at specific receptors associated with particular brain functions. So there's a lot of work that's being done in that space. It's not, especially, yeah. I think dementia is probably the biggest neurological application, but there's definitely some applications that we do in that space.
Yeah, especially when you're talking about theranostics, and it seems that you've got so many options now where you can combine all these different strategies.
Yeah, theranostics is difficult with some disease like psychiatric disease. You wouldn't be putting a therapy dose to it, but they are looking at theranostics for Alzheimer's disease because you're targeting the beta amyloid plaque formation. So there are some theranostic approaches they're looking at there. I think they're a way off, but certainly cancer is the main theranostic.
Armando Aragon has a question of why nuclear medicine sometimes the last option for most of the patients?
Yeah, it's a last option for a few reasons. Number one, it's more expensive, so you kind of start with your cheapest option. So a quick X-ray is the easiest thing to determine if someone's got a fracture, for example. And it's just its nature. It takes a bit of time. It's not an instant image. You inject the patient and bring them back an hour later or 2 hours later, sometimes the next day. And so it's usually reserved for, and it's not as widespread. So, ideally, like if you could screen the whole population with all these different tests, then we'd have nuclear medicine everywhere. But that's unrealistic and not going to happen. So it's usually just reserved for those cases where simpler tests fail.
It's an eye opener that the market continually in expanding, as you mentioned it earlier on. There's another question, what about is there any effort underway to redesign the radionuclide binding portion of the pharmaceutical to better retain the daughters of alpha therapy nuclides?
Certainly that's so. As an example with actinium, certainly there's a lot of work being done on trying to understand how you can actually capitalize on the advantages of the actinium alpha decay and eliminate potential collateral damage from its daughter products. And there is work. I know that ANSTO is doing work in that space. There's a lot of work being done overseas. The challenge is that the solution might be that if it breaks down or dechellates, then you've got to have some other chelator that actually then consumes it for elimination. So it might be increasing your renal dose. But one of the other things that we're doing is actually going further down the chain. So instead of starting with actinium, let's go down to lead or astatine and actually say, okay, well, let's skip 4 of the daughters and actually just go to this alpha and make sure that's chelated. And some of them have short half-lives, so they're difficult to try to work out how you manage a new element with a very short half-life of seconds before it becomes a new element again. So very challenging.
That's a great pointer on the astatine, because there was actually a question, what about the 211 astatine?
Yeah. And so just looking at different parts of the decay cycle and other products.
So a question again from David Cohen was do we know what's the typical fraction of radionuclide is retained in the body permanently, and is there any long-term effects from this or other than radiological effects?
Yeah, so we do. We can model that, and it has been modeled. That's what all of the MERD dosimetry is about. It's not just about dosimetry, but it models the biologic behaviour. But the basis of nuclear medicine is the tracer principle, right? And we know, if you've watched a James Bond movie, you'll know that thallium, for example, thallium-201 is a poison, and it was used in one of the recent Bond movies as a poison. Anything in high enough doses is a poison, right? They're toxic to the body. But nuclear medicine relies on the tracer principle. We use such small amounts of the actual chemical, and even though the numbers sound large, like 1 billion radioactive atoms, is it in the scale of the human body, it's actually nothing. And as a result of that is that we don't actually produce those sorts of, the toxic effects are going to come from the therapeutic dose or an alpha, not from having the chemical in the body that is largely, when it is decollated, eliminated. So you will actually get retention. So for example, technetium is the great example. Technetium-99 M decays with 6 hours to technetium-99, which has a 100,000 year half-life. So if it's not eliminated from the body, it's there until you die. So most of it will be eliminated from your body, but it's still the tracer principle. It's so little amount of it that it's actually not going to change.
Yeah, that's a great answer, and it's the way that you kind of framed it as well, by saying how the dose from these radiotherapies is so much lower than, say, like a CT scan, which everyone gets about even thinking twice about it, right? Yeah, so thank you very much. I think like the audience is basically generally saying thank you very much for such an amazing presentation. It's all going to be on vid, so everyone can go back and review and do all the grabs. I certainly learned a lot and got updated. But yeah, I mean, I guess like if you got like a little bit more, just the tad, maybe like a sum up, a couple of points about how AI is being integrated, maybe that could be your last word.
Yep. So I guess that if we skip through to AI, is that let's ignore generative AI. There's some really cool applications that we're using for auto segmentation. I mentioned, like the density of this data when we've got hybrid imaging of PET and MRI and PET and CT and SPECT and CT, to handcraft regions of interest and segment organs for analysis is virtually impossible to get reliability. So AI is driving that. We can actually use it to extract radiomic features, in particular fourth order radiomic features that are associated with things that the human eye doesn't see. So it's patterns that we can't actually appreciate that might be predictive of disease and outcomes of patients. This is the kind of AI display, predictive display that people might see in the future. That's out of the US. And just things like reducing that radiation dose by eliminating the CT. If we're not using it for diagnosis, we're only using it for attenuation correction, well, then we can actually produce what's called a pseudo CT by training a neural network to be able to use the MRI or the PET scan to create a CT scan for attenuation correction. So that's actually, and it does it with a 1% accuracy, which is pretty significant. Direct sinogram, and the other thing is the denoising images. This is a bit of a trap, really. It means that we can use an artificial neural network, in this case a UNet, to improve the way that images look, but we need to keep in mind that the original image, the original data itself, has not been changed. We haven't enhanced the data. So as a result of that, then the trap is that when we do our quantitation, it's still low statistic data and has the potential for error. So you're still better off using things like our solid state detectors to improve your sensitivity and increase your counts. So that's probably where AI in a nutshell, but there's so much more that's going on in that space. Anyone that's interested certainly can read it in one of those articles.
Thank you so much, Professor Currie. I guess, I'll just thank you on behalf of our audience today, of which everyone's completely fascinated and engrossed by all the details and all the developments currently. And thank you very much for everyone for showing up. And giving a great audience.